Hello everyone, welcome back to my YouTube channel Dr.Barki's Ophthalmology Tutorials. Today we will discuss about third cranial nerve palsy. This video is going to be a little lengthy as I am going to discuss most of the things related to third cranial nerve palsy, and this is going to be a very useful video for postgraduates. So without much delay, let's begin our video on third cranial nerve palsy. So I will be going to discuss this third cranial nerve palsy under the headings of types, causes, symptoms and signs, special situations like ophthalmoplegic migraine, oculomotor nerve palsy, what are the investigations you should do whenever you have third cranial nerve palsy patient, how do you manage the case, in that again medical management and the surgical management. So if you come to types of third cranial nerve palsy, it can involve either one eye or it can affect both the eyes. Then it's called as either unilateral or bilateral third cranial nerve palsy. So if it is present since birth, it's called as congenital, and if it is acquired later in the life, it's called as acquired palsy. As you all know, the oculomotor nerve has superior branch and the inferior branch. Again, the superior branch supplies the LPS and the superior rectus, and the inferior branch supplies the medial rectus, inferior rectus and the inferior oblique and even the pupil. So this can be partial third cranial nerve palsy if it is affecting few branches of the third cranial nerve, and it is called as complete when it is affecting all the motor branches of the third nerve. And it can be either pupil involving or pupil sparing. So whenever there is complete third nerve palsy, it will be pupil sparing complete third nerve palsy, or it can be pupil involving third cranial nerve palsy. Don't get confused when you are using the word complete when you are describing third nerve palsy. So it can be complete but still can spare the pupil. Okay. So what are the causes for third cranial nerve palsy? This I have already discussed in my previous video on the anatomy of the third cranial nerve. This is to just give the most important causes in children and adults altogether. Okay. So in children, the palsy is mainly because of the congenital, which is accounting for 43% of total palsy in case of children. The second is we have trauma, then inflammation, aneurysms, and even some cases because of ophthalmoplegic migraine. If you come to adults, the most common causes are vasculopathic, that is secondary to diabetes or hypertension, can be because of aneurysms and even trauma. So depending upon the presentation, you can locate the anatomical position where the nerve is affected. So suppose the patient has nuclear complex level lesion, so how the patient will present. So that depends upon which subnuclei of the third cranial nerve is affected. It can be complete affection of the whole of the nucleus, or it can be some subnuclei of some muscles. Okay. So depending upon that, the patient will present, and that is seen when the individual nucleus is affected. Suppose the nucleus which is supplying the inferior rectus, that is the dorsal nucleus, is affected, then only the inferior rectus muscle is affected. So if the nucleus which is supplying the medial rectus is affected, that is the ventral nucleus is affected, then only the medial rectus is affected. So that is the scenario in case where the individual subnuclei is affected. If whole of the third cranial nerve nucleus is affected, then it is usually bilateral in presentation. Means the nucleus which is supplying the LPS is affected, then there is bilateral affection of the LPS. Means both eyes LPS is affected, so there is bilateral ptosis in presentation. And the nucleus of the superior rectus is little tricky. So typically we are going to describe these nuclear lesions as bilateral because there is involvement of both the eyes LPS muscle. So whenever there is complete third nerve palsy, both eyes LPS is affected, hence both eyes will have ptosis. And as you know, the superior rectus subnuclei will supply the contralateral superior rectus muscle, right? But here what you should understand is the crossing of the fibers will happen at the nuclear level only. So the superior rectus of the say right eye moves to the other eye superior rectus nuclei. Okay. So similarly, the superior rectus fibers of the left eye nuclei will move to the superior rectus nucleus of the other eye. Clear? So whenever the superior rectus subnuclei is affected, it will affect both the eyes superior rectus muscle. It's not like if the right eye complete nucleus is affected, it doesn't mean that it will spare the superior rectus of the right eye, because the fibers of the left eye are passing through the subnucleus of the superior rectus of the right eye, it is also affected. So there is bilateral involvement of LPS and the superior rectus. So whenever you have a complete third nerve palsy which you are locating to the nuclear level, then there is complete palsy of the one eye, means muscles which are supplied by the third cranial nerve on the same side like superior rectus, LPS, medial rectus, inferior oblique, all are affected along with the LPS and the superior rectus of the other eye. So this is how you can locate the lesion to nuclear level. So the causes can be here because of the vascular diseases, or there can be primary tumors which are affecting the nuclear level, or it can be secondary to metastasis. There is one more entity called as Webino, that is nothing but walled eye bilateral internuclear ophthalmoplegia. This occurs whenever the medial rectus subnuclei are affected, that is paired medial rectus subnuclei are affected. So both eyes medial rectus are not working, so there is unopposed action of the lateral rectus muscle. So both the eyes are moved out, leading to the condition called as walled eye internuclear ophthalmoplegia. Whenever there is complete affection of third nerve nuclear complex, there are more chances of involvement of the fourth nerve also, which is just located caudal to third cranial nerve nucleus complex. Moving on to the fascicular part of third cranial nerve. As you all know, this is the part of the third cranial nerve which is traversing the midbrain, right? So when there is affection of the cranial nerve at this point, the causes can be because of the vascular lesions again. It can be because of the primary tumors or metastasis. Here one more involvement compared to your nuclear level is the demyelinating diseases can also affect the fascicular part. So when the third cranial nerve is affected here, as you can see, it is in close approximation with the red nucleus as well as the cerebral peduncles. So if there is involvement of the third cranial nerve along with the red nucleus affection, it will lead to what is called as Benedict syndrome, where the patient will have ipsilateral third cranial nerve palsy with the contralateral tremors. And when the nerve goes down and when there is affection of the third cranial nerve at this point, that is at the level of cerebral peduncle, there is ipsilateral third cranial nerve palsy along with the contralateral hemiparesis. So if the affection is at the level of the cerebellar peduncle, then there can be cerebellar ataxia along with the ipsilateral third cranial nerve palsy. We have one more syndrome called as Claudius syndrome, which is nothing but combination of red nuclei affection and the cerebral peduncle affection. It means the lesion is so big that it is involving the third cranial nerve as well as the red nucleus as well as the cerebral peduncle. Okay, so you can locate the lesion to fascicular part whenever there is associated tremors or the hemiparesis or the cerebellar ataxia symptoms. So coming to the basilar part. So as the nerve runs in the subarachnoid course, it is not accompanied by any other cranial nerves. So isolated third nerve palsy is mainly located to the basilar part. The common causes here again are aneurysms, or it can be secondary to head injury. So the aneurysms of the which artery? So as you can see, this is the third cranial nerve which is passing between posterior cerebral artery and the superior cerebellar artery. It is traversing parallel to the posterior communicating artery. So if there is any aneurysms or the hemorrhage or enlargement of this posterior communicating artery, that will lead to third cranial nerve palsy. The second common thing is because of the head injury. So what happens when there is head injury? So if there is any extradural or the subdural hemorrhage as it is shown here, it will increase the intracranial pressure and it will lead to the uncal herniation. Okay, as the third cranial nerve passes through the tentorial edge, it can get compressed whenever there is uncal herniation. This will lead to initial meiosis because of the irritation of the superficial fibers of the oculomotor nerve, later followed by mydriasis. This is called as Hutchinson's pupil. So whenever there is uncal herniation secondary to extradural hemorrhage, patient can just have only the pupillary involvement, that is pupillary dilatation without any extraocular involvement, or there can be only extraocular muscle involvement without pupil involvement. So moving on to the intracavernous part of third cranial nerve. Here the patient typically presents with involvement of other cranial nerves along with the third cranial nerve. Means there is involvement of the fourth, sixth as well as first division of the fifth cranial nerve. So usually the presentation will be like painful ophthalmoplegia. Then you can locate the lesion to intracavernous part. So the causes again here are secondary to diabetes, or it can be because of the pituitary apoplexy, aneurysms, meningiomas, or carotid cavernous fistulas, or granulomatous diseases like Tolosa-Hunt syndrome. Moving on to intraorbital part of third cranial nerve. It is usually secondary to trauma. It depends upon which branch of the nerve is affected. If the superior division of oculomotor nerve is affected, it will lead to affection of LPS and the SR. The inferior division is affected, it can affect inferior rectus, inferior oblique, or the medial rectus muscle along with the sphincter pupillae as well as the ciliary muscle. So patient will have the problems with accommodation also. So hope now you understood how to locate the lesion to anatomical position of the third cranial nerve. So coming to the pupillomotor fibers, If there is involvement of the pupillomotor fibers, then it will lead to pupil involving third cranial nerve palsy. Means along with other signs of the third cranial nerve palsy, there is involvement of the pupil also. If there is pupil involving third nerve palsy, it means that the cause is surgical, like secondary to aneurysms or secondary to trauma or uncal herniation. If the pupil is spared, it means that it is secondary to medical causes like hypertension or diabetes. But this is not strict rule. Means even the surgical causes like aneurysms, initially the pupil can be spared and later it can get involved, and in some cases of diabetes and hypertension also there can be involvement of the pupil. And sometimes the pupil involvement can be the only sign in third nerve palsy, like in case of basal meningitis or secondary to uncal herniation, as I discussed before. And the pupil involvement can be partial or it can be complete. And even a mild involvement of the pupil should be considered seriously. It can be a precursor of the surgical cause. Okay. So how the patient will present with? If it is evolving third nerve palsy or if the eyelids are spared, then patient can have double vision. It can be either complete ptosis or partial ptosis. And the patient can experience the other symptoms of paralytic squint like nausea, vomiting. So moving on to signs. So whenever you have the cranial nerve palsy as your case, you should always do complete CNS examination. Okay, means it includes the examination of all the cranial nerves along with the cerebellar signs also. So the patient will have ptosis. So as you can see in this picture, this patient is having complete ptosis because of the LPS affection, and when the eyelid is retracted, the eye can be down and out. This is very well appreciated in this patient. So as you can see here, the patient has complete ptosis of the left eye. This is one more patient who is showing partial ptosis. Okay, you can still see the lower half of the cornea, and when you lift the eyelids, the eyeball is down and out. Okay, so as you can see, the left eye is hypotropic and it is in the exodeviation position. And when you look into the ocular movements, as you can see in this picture, the lateral rectus is normal, there is complete abduction, whereas the medial rectus of the other eye is affected, so the adduction is limited. You can see the elevation is limited, the depression is limited, so all the branches of third cranial nerve are affected. So now the question is how to check for fourth nerve, that is the trochlear nerve, whenever the patient has third cranial nerve palsy. So that is appreciated under the slit lamp examination. So just ask the patient to adduct and look down in this gaze, then you will appreciate a conjunctival vessel which is just trying to intart. Okay, so that indicates that there is functioning fourth cranial nerve. So you should also look for the aberrant regeneration. So what is aberrant regeneration? It can be primary or secondary. Don't get confused between the primary aberrant regeneration and the congenital aberrant regeneration, which is seen in case of congenital third nerve palsy. So a patient who has acquired third nerve palsy has aberrant regeneration without any history of trauma or aneurysms, means that is considered as primary aberrant regeneration, and this is one of the most important clue for your surgical causes for third nerve palsy, and you have to get the investigations done immediately. If it is happening secondary to trauma or the aneurysms, it's called as secondary aberrant regeneration. So this occurs during repair stage. So as you all know, we have what is known as endoneurium, which are covering the sub branches of this oculomotor nerve. Okay, so if there is any misfiring of these nerves, means a nerve which is supposed to supply the medial rectus is supplying the LPS. Whenever this muscle is put into action, the LPS will be contracting. The second scenario is like if there is a nerve which is supposed to supply the inferior rectus is supplying the LPS muscle, then there is contraction of the LPS whenever the patient is trying to look down. As you can see in this picture, so this is the position of the eyeballs in the primary position in the healing phase or the later part of the oculomotor nerve palsy. So this patient is trying to look down. Okay, so this is the affected eye. The patient is not able to look down, but there is a retraction of the upper eyelid. Okay, and we call it as pseudo Van Graff's sign whenever there is upper eyelid elevation on attempted adduction. Okay, even there can be miswiring from the various nerves to the pupil also, means a twig which is supposed to supply the medial rectus can supply the pupillary muscles. Then there will be segmental pupil constriction on attempted adduction or elevation or depression. This is about the aberrant regeneration. So moving on to some special situations, that is ophthalmoplegic migraine. So this is very rare phenomena. It is usually seen in children with a history of migraine. Here the patient will typically have ocular pain, nausea and vomiting, which will precede the onset of palsy and will come down once the paresis is set in. The next entity is cyclic oculomotor palsy. Again, it's extremely rare phenomena. Here there is intermittent spasm of the paretic eye. So during spasms, the paretic eye returns from its exotropic position to the normal position, and there is improvement in the ptosis and the pupil constriction. That is cyclic oculomotor palsy. What investigations you should do whenever a patient comes with oculomotor neuropalsy? Rule out the medical causes by these investigations like RBS, CBC with ESR, do the lipid profile, rule out the homocystinemia. Then go for neuroimaging. So what neuroimaging you should order for? It is usually MRI or the MRA. So when it is indicated, it is usually indicated whenever the patient is less than 40 years. If the patient is more than 40 years with a pupil involvement, or if there is partial and evolving third cranial nerve palsy, and if there are no signs of resolution even after 3 months of onset, and if there are signs of aberrant regeneration, and if the patient is presenting with multiple cranial nerve palsy, then you have to order for MRI. The aim of management of third cranial nerve palsy depends upon the age of the patient. In children, here the main aim is to prevent the amblyopia, whereas in adults it is to achieve binocular single vision in the primary position. Third cranial nerve palsy is very difficult to treat. That depends upon the extent of the paresis, how much is the recovery, and is there any aberrant regeneration. So we have short-term treatment as well as the long-term treatment. Short-term is usually medical line of management and the long-term is surgical line of management. So the medical treatment is indicated up to 6 months or when the surgery is contraindicated. Here we use occlusion therapy, or you can go for the prisms, or you can use the botulinum toxin, or the combination of these. So what are the uses of occlusion therapy? Occlusion therapy is to alleviate diplopia as well as to prevent the contracture of the antagonist. Okay, that is the lateral rectus muscle. So how you can do occlusion? It can be like indoor occlusion or the outdoor occlusion. In indoor, or whenever the patient is inside the house, you just occlude the normal eye, so the abnormal or the paretic eye is used. The patient is going out, then patch the paretic eye and let him use the normal eye. Either use the patches here or go for opaque contact lens or blurred spectacle. So coming to uses of prism, it has very limited role because there is multiple muscle involvement. In case of third cranial nerve palsy, the prism use is limited. It is helpful only when there is predominant medial rectus involvement and the medial rectus recovery is incomplete. And sometimes you can use the prisms once you neutralize the horizontal deviation. Then for the remaining amount of the vertical deviation, you can use the prisms. Okay. So botulinum toxin, it is useful in the acute phase, especially useful when there is isolated involvement of the medial rectus muscle. You use the botulinum toxin to the antagonistic muscle, that is the lateral rectus muscle, so that the patient will not have double vision. So coming to the surgical treatment, the goal is to achieve the alignment in the primary position. You may compromise the ocular motility, but you want the eyes to be in center in the primary position. The aim is to alleviate the diplopia and to alleviate the abnormal head posture. The surgical management depends upon which muscle is involved and how much is the recovery. So if there is isolated medial rectus involvement and which is not recovered, then you can go for supramaximal resection of the lateral rectus, say some 14 to 16 millimeters, with a large resection of medial rectus, say about 8 to 14 millimeters if there is unrecovered medial rectus muscle. And if there is paresis of the superior rectus muscle, then go for medial rectus and the lateral rectus transposition to the superior rectus muscle if the inferior rectus FDT is negative. Means you do the FDT and the FDT comes negative, then go for NAPS procedure, that is transposition of medial rectus and the lateral rectus to superior rectus muscle. And if the FDT is positive for the inferior rectus, then do inferior rectus resection. NAPS has also suggested the LR transposition to the inferior rectus insertion and superior rectus to the medial rectus insertion with a tenotomy of the superior oblique to align the eyes in primary position. So this was all about the third cranial nerve palsy. Hope this video is helpful to all of you. If you like my videos, please do subscribe to my channel. Press the bell icon for further notification. Please do like and share my videos. Thank you so much.